So just wanted to present the update for the new NG feeding guideline for ITU that we updated at the end of that last year because there was a few changes. So if anybody wants to, if anybody isn't aware of it, this is the guideline that you need to search for, C24/2020. So it may be different from if you've come from an area that not critical care, there's a different feeding guideline. So you may not be familiar with the ITU version. And we do see some very random things happening with prescriptions on ITU. So I just wanted to make you aware so that you're doing the right thing. So we have a feeding guideline to prevent delay in starting enteral feeding prior to dietitian assessment. And we're very short-staffed at the minute with maternity leave, and we've had quite a bit of sickness over the winter period as well. So it's important that you know that you start the right things. And it's a proactive strategy to reduce disease severity, and so for many years there's been sort of evidence about the right amount of enteral feeding being protective for the patient and protecting the gut, reducing bacterial translocation, but the right amount of feeding is critical. And exactly what the right amount of feeding is still debatable, but what is clear is overfeeding is really bad. So this guideline has been updated to reduce the target rate for feeding our patients. So it's split into different flow charts. So the first flow chart is very sensible with, it has the patient got a functioning accessible gut? If no, we would consider parenteral nutrition. And we certainly don't need to rush into parenteral nutrition for the majority of the patients. So unless they're extremely malnourished, we would say making decisions about PN could be around day 5. If we have got a functioning gut, then we put in the right sort of feeding tube. Now, the ideal feeding tube for most patients would be the 12 French combined drainage feeding tube, unless you needed rapid decompression of the stomach, and you might want to choose a size 14. But obviously, there is a risk of pressure sores around the nose area. So the bigger the tube, the more problematic that can be. So first line is the 12 French tube. We do stock the 14s and 16s as well. We also stock the 8s, but the 8s are designed for long-term patients once we've got out of the acute phase, so for a rehab patients, and we can only have 8 on discussion with the MDT, so the nurses have got those locked away so we don't accidentally put 8s in for somebody that we need to rapidly decompress the stomach. And we just want you to think, what sort of tube would you want to wake up to if you were in ITU? Would you want a 16 French or would you prefer a 12? Just so for me, for information, I'd like a 12, please. They do look the same, and so that's just where you find the information on the packaging. So it is there on the back if you know what you're looking for. And a lot of people aren't familiar with the difference between the Riles tubes. So a feeding tube will have a purple end like this. If you can't see a purple end on the tube, it's a Riles tube that's probably been put in theatre, sometimes deliberately to stop people feeding down them. So for esophagectomies, for example. They are significantly cheaper, so quite often we do see them coming from theatres with a Riles tube, which sometimes can be a little bit annoying because we want to feed down them and then we have to change them on the unit. But look for the purple end. So a new change to the guideline is we want everybody who hasn't got CKD to have forcible soluble prescribed. So forcible soluble is a micronutrient supplement. So we want to give everybody 100% of the micronutrients from the start, because we're going to be going slower with the enteral feed. They're going to be getting less micronutrients from their enteral feed. So this is a new change that, unless it's contraindicated, we're asking this to be prescribed at the start. That's for everybody, not just whether they're at risk of refeeding syndrome. If they are at risk of refeeding syndrome, then we would want B vitamins and thiamine and vitamin B co-strong. If the enteral route can be used, it's far cheaper to give thiamine and vitamin B co-strong. But if they need intravenous, then we can give I think it's still intravenous thiamine at the minute until we've used up the stocks, but it will be moving to intravenous B and C injection once we've used up those stocks. So until the feeds are on target rate, the feeds won't provide 100% of the micronutrients, and there's evidence which is outlined in the European Society of Enteral and Parenteral Nutrition that specific trace elements and vitamins having deficiencies can worsen disease. So we're just covering all bases. So particularly zinc, copper, vitamin D, low levels of these are detrimental, but actually measuring them when patients are in ITU isn't always the best idea, because when your inflammatory markers are raised, then they always come back abnormal, and then we don't know when to supplement. So unless we've got a clear indication of when we should supplement, we should wait until the patient's a bit better before we measure those, which will then give us a better picture. And then, yeah, so Appendix 3 just talks about what the differences are with risk of refeeding syndrome. So refeeding syndrome, just as a summary, most of you will have heard of this. It's been around for a long time, sort of dating back to the Second World War, when it was mainly recognised when people were left the concentration camp and started to eat, people died. So it's a metabolic syndrome, switching from a fasted state to a fed state, and particularly your potassium, your phosphate and magnesium all shift once you give carbohydrate source, so you stimulate insulin production, and then everything moves into the cell, and so your phosphate, potassium and magnesium drop. Patients are deemed at risk if they've got a low BMI of less than 18.5. However, you could be eating quite well and have a low BMI of 18.5 and you won't be at risk. If you've unintentional weight loss of 5 to 10% in the last 3 to 6 months, and pretty common for hospital, to be honest, is if you've had no nutrition for 5 days, that comes up quite a lot, because it's very easy to sit on a surgical ward, for example, waiting to see if you're going to settle before you have any nutrition. And by the time you have surgery, you could be 5 to 10 days or even a bit longer. So we do see a lot of patients that fall into that category of more than 5 days without any nutrition. And we often get asked, how rapid is refeeding syndrome? So I've certainly seen patients, like, I've been working for a long time now. So in the 1990s, late 1990s, it wasn't something that was particularly recognised. We didn't give thiamine, we didn't start feeds off slowly. And I did have a patient who died of a cardiac arrest just several hours after the feed started. And when I said to my supervisor at the time, I said, I was really worried. I was talking to him, he seemed fine, and then he died. And she said to me, well, that happens a lot. So back in 1997, people were just dying from refeeding syndrome and nobody really knew that was a thing. This second case study sort of shows how it can be a little bit longer. So this is a lady with Crohn's disease. She'd lost 18 kilograms. Her weight was 35 kilos with a BMI of 13, and she was referred for NG feeding. And at this time, she was identified as a very high risk of refeeding syndrome, and the right things were done. B vitamins were commenced and a very low rate of feeding. But where she ran into problems was her phosphate was high, very high pre-feeding. But as you can see, the drop is really rapid over those days. But unfortunately, because at day 4, her phosphate was still high, everybody thought, well, that's fine now, we don't need to worry, stop checking the bloods. So day 7 is when she had a cardiac arrest. She was transferred to ITU and her phosphate was 0.1. Magnesium was 0.4 and she died. And at the time it was put on a death certificate, natural causes, but it was a very high suspicion of refeeding syndrome. So we just need to be really clear that we keep monitoring refeeding syndrome even when bloods are okay. So it's unlikely that sort of thing would happen on ITU, because you do those checks all the time. But for patients that we discharge to the ward, we need to be really clear that we want them ongoing to be monitored.
How long should we do the feed test for?
Until stable. Yeah, so obviously that not until normal range, but yeah, that stable word is really important. So then moving on to the next part of the guideline is about checking for allergy status. As prescribers, it's really important that you know that the feeds will contain allergens. So the main thing that we do seem to come across is fish allergies. So Nutrison Protein Plus does contain fish oils, as well as pea protein, coconut oil. So if anybody has got an allergy, then it is definitely worth checking before we start the feed. And we have had a patient recently who had an allergy to fish. It was identified, but Nutrison Protein Plus was hung up. 24 hours later, after the family said, you know, my wife's got a fish allergy. The feed was stopped and changed to Nutrilon soya. 4 hours after the Nutrilon soya started is when the reaction started. So then the Nutrilon soy was stopped, and then the patient didn't get any feed for the rest of the weekend. It's always a weekend, of course, when there's not a dietitian around. But actually, sort of working backwards, it was because of 24 hours of Nutrilon Protein Plus that was issued, not the Nutrilon soya. But that's where then the confusion came about what we could give afterwards. So do assess that, and then the maximum rate of feed that you can now prescribe is 30 mils an hour if they're under 50 kilos and 40 mils an hour if they're over 50 kilos. So that is different from the previous protocol. It was 40 mils an hour and 50 mils an hour. So yeah, checking your allergies. It can be a bit of a faff checking allergies. I had a patient who, it said, it was a patient on PN that was documented a nerve centre egg allergy, and because of the phospholipids, you can't give PN with an egg allergy. But after an awful lot of investigating and looking through medical notes, the patient had been eating egg mayonnaise sandwiches pretty much every day while they've been in hospital. So one comment from a family member at some point can end up as an allergy or nerve centre. So it can work both ways.
That's mustard okay?
Sorry?
Mustard okay?
Mustard is okay for these feeds, yes. So if you... Does it? Yeah, I mean, it is one of the allergens.
I've never quite figured it out.
Right.
It's really annoying, so it's in a lot of sources. What it is.
Can they do testing on that? Because I think they can do a lot more tests now than they used to be able to do specific. Yeah. Yeah. Yes. Yeah. And I expect there's a lot of checking that goes along with that. So if you're not sure, the allergens are identified in bold in the ingredients on the back of the feed. However, it's only the allergens that are considered essential by under the European standards. So it's not all allergens. So pea protein, I've been told there's 4 people in Leicestershire. There's 4 people in Leicestershire with pea protein allergies, and pea protein is not one of the identified allergens. So if one of those 4 people come in, we just need to not give them Nutrilon Protein Plus. So once we started, we prescribed the right feed, then we've obviously changed the maximum rate. And the reason for this is because it's so important not to overfeed in the initial phase of critical illness. So that is the time when you're least likely to have a dietitian, because you know patients will start out of hours. But you often give other non-nutritional sources of energy. So when we audited this in 2023, on the LRI site, our propofol use had increased from 34% to 84% of patients. Over 20% of patients were exceeding their energy requirements by day 2, and that had increased from previous audit of 12%. The protein provision was still the same, so it was kind of identified that it was because of the non-nutritional sources of energy. We had some patients that within the first day were receiving 125% of their energy requirements from non-nutritional sources. So you've got your propofol, which is 1 calorie per mil. You've got citrate, which has got 0.59 calories per millimole, and you've got dextrose as well. So some patients are on loads, and just to demonstrate that with this case study. So this is a lady, 70-year-old lady with a pressure sore, necrotizing fasciitis, weight of 76 kilos, BMI of 26. Her estimated requirements were about 1,520 calories, but when we went to see her, she was already on 360 calories from propofol, 380 calories from citrate, and 380 calories from IV glucose. So, you know, she's nearly getting her, well, she's overfed if you go for less than 70% of requirements, just from non-feed sources. So it's actually then quite difficult to, you don't have much nutrition to play with, really. So that's why it's really important that we then give micronutrients, and we could top this person up with protein sources, but really we would be looking at, is there anything that we can do to reduce that calorie load? So the next bit of the flow chart is patient tolerating the NG feed. Gastric volumes is only one measure of tolerance. I don't really like gastric volumes because they never really tell you what you want to know, and that you can get 0 gastric volumes with patients with distended abdomens whose bowels haven't worked 7 days, who are clearly not tolerating the feed, but gastric volumes are really low, so they kind of lull us into a bit of a false sense of security. And then also you can have patients that have got soft abdomen and working bowels, and gastric volumes over 400 mils. And there is a lot of debate as to whether we should actually be measuring these or not, but I'm not going to open that this Friday afternoon. It is a marker that we would use at the minute, and if gastric volumes are more than 400 mils on 2 occasions, then we would start to reduce the rate of the feed. So you've got your maximum rates there, but I'd also note in the corner there that if they are on high doses of propofol or dextrose, consider just trophic feeding, because it's more harmful to overfeed than it is to underfeed in the first few days on critical care. And you will see more and more that when dietitians do come to review after the patient's been on protocol, they quite often cut it down a bit from what they're on already. So tolerating the feed, yeah, and there's a new prokinetic guideline. I don't know if it's out yet. I've seen pharmacists circulating that for comment, so that's about to come out as well. But obviously that's something that if they're not tolerating, that we can discuss whether they need prokinetics or not. So just a summary then, it's been updated. It's based on evidence. It's very similar to what a lot of hospitals use. It doesn't cover every eventuality because you can't protocol every single patient, but it's just something that you've got to follow when the dietitian's not there, and flagging up the allergies and the maximum rate is really, really important, and then and also adding the forceful as a new thing. Okay. Any questions? Any questions from the floor? I don't know who's there. I can't see anything.
Are they? What's the new
Yeah. So I think it's erythromycin now. Yeah. And I don't think routinely using them together. But I'd have to go back and check that. But yeah, I think it's going to critical care core group at the next meeting, and then that'll come out. Yeah, and sometimes you do both together as well. Yeah.
But the new guideline says.
Think so, but we'll have to double check that when it comes out.
So in terms of what we prescribe in the middle of the night,
Yeah.
is it forceval?
Yeah, forceful. Yes. Yeah. And you'll find that under the refeeding medication.
Like energy feeding chart that we want to sign as well?
So you would use Neutral and Protein Plus unless they've got any allergies.
Okay.
And you would yeah, you need to sign that on nerve. It's on nerve centre, yeah. So 30 to 49.
Yeah.
If in doubt, go lower. Yeah. If they're less than 50. Yeah. Or you're on propofol. Yeah. Do 30 if you're not sure. And if they're on a lot of other stuff, do 20. Yeah. If they're on a lot of propofol, yeah. Yeah, everything. If they're on absolutely everything, give them 10 mils an hour. Just give them a little bit less, and then we can sort of figure it out when they're a bit more stable.
You said that propofol 1 calorie per mil. How many calories are in a bag of like 5%?
So you've got 200 calories in a litre of 5%. So then it's 400 in 10%. You can end up with quite a lot of calories. So particularly patients that are on 50% dextrose.
Do you calculate the calories that are in the nest up your iron stuff?
Yeah, we don't do that yet. So we would only calculate it if they were on an infusion of dextrose rather than those bits. So we calculate the citrate, the propofol, and the IV infusions.
So it gets a bit, probably more value than it needs to be.
Yeah. Okay, cool. So there's no other questions. Thank you for listening.
Thanks, Jane.
Bye.
Thanks, Moira.
Thank you. Bye.